What do people know about diabetes?
Unhealthy eating and not exercising, basically not being fit. That's what causes sugar diabetes.
Diabetes is caused by a lot of sugar and eating excessive junk food.
Diabetes is caused by a lot of fat, not eating healthy, less of exercising, and too much sugar.
Are you losing weight without the intention of losing that weight? Do you have this tingling and numb feeling in your hands and feet? And do you get blurry vision? Do you find yourself urinating a lot and often at night as well? Well, these are some of the symptoms and maybe your wake-up call for you to step out and go to a health center so that you can get checked out because you could have diabetes. Hello and welcome. I'm your host, Dr. Musamtomeni. Signing with us today is Hlengiwe Msingali. On Vital Signs, we focus on diabetes. Coming up on the program, we'll listen to an insert produced by Zama Buthelezi. She spoke to two men, one living with type 1 diabetes and the other with type 2 diabetes, and they get to share their experience with us. We'll speak to principal specialist and head of endocrinology and metabolism at Chris Hani Baragwanath Academic Hospital about the types of diabetes, prevention, treatment, and risk factors, and he'll be with us throughout the show. And of course, we'll also speak to somebody else, and this is someone at the National Diabetes South Africa, and that is the national chairman at Diabetes South Africa, about the importance and the impact that the organization has on communities. Remember that you can be part of the show by really involving yourself and asking the guests that we have on the show some questions that you have on your mind. Simply share your views with us on what we're discussing. The number is 011-714-5861 or 011-714-5877. Also on social media, you could send your questions and thoughts to us. It's at SABC Vital Signs on Twitter and SABC Vital Signs on Facebook. We continue our discussion talking diabetes today right after this ad break. Welcome back. This is Vital Signs on SABC. South Africa has the highest prevalence in Africa at 11.3%. And of course, the country has registered an estimated 96,000 diabetic deaths this year alone. Now, the estimate, of course, is just under half of the people, 45.4, living with diabetes in South Africa are undiagnosed. When undetected or inadequately treated, people with this condition are at high risk, of course, of having serious and life-threatening complications such as heart attacks, strokes, kidney failure, blindness, and of course, lower limb amputations. Zama Buthelezi sat with Frans Steenkamp, who's been living with type 1 diabetes for years. Let's take a listen to his story.
Gauteng resident Frans Steenkamp has been living with type 1 diabetes for more than 40 years. He spoke to us about the day he received his diagnosis.
About 6 weeks on my 24th birthday, I realized some strange symptoms like running to the toilet a lot, and I'm tired. A lack of concentration. I started to lose weight as well. So I decided, no, let's make an appointment with the doctor and let's test for diabetes. So I went for a test, and the doctor said I must take up in hospital for some observation. Okay, and the rest is history.
Was there a history of diabetes in the Steenkamp family?
No. It was quite a shock for my family, you know, young, 24, and suddenly diabetes. Yeah, it was quite a shock for the family.
Stress and frustration have seen many people giving up after receiving their diagnosis.
I went to the old Johannesburg General Hospital, and the medical doctor, Dr. Hahn, said to me, Frans, get your life together, get your act together, get your lifestyle right, you can have a good life. Or you could be a burden for your wife and your family when you get older. And that was a total wake-up call for me.
Many patients complain about the cost of the healthy diet and treatment for diabetics.
if you talk about something healthy, it has a major price tag on it. But you got basic no choice. You have to consider what is the best under the circumstances. Use the right food, use the exercise, but the food, make sure you don't go, okay, today because of the price of this item, I use something else. I know it will damage. You must consider just the best, because that's what we are surviving.
Government has warned that people with comorbidities must take extra care and vaccinate. Have you heeded the call?
Back in end of May, when I say the people over 60 have to vaccinate, I decide I have to. I register on Discovery for me and my wife, without telling her, because she's still young. She's 6 years younger than me, and she's working at the nursery school with kids. I know she have to also vaccinate. So I registered, and she got an SMS and said, no, you must come on Friday. So I said, but I didn't register. I said, I register us. I think we have to go. And that Friday morning, when at 12 o'clock, I pick her up at work, and we go home, and she said, you know, I decide I have to go with you. So we did the first one, and 42 days later, we did it for the second one. Luckily, we didn't have any illness of anything. Just a little bit sore on the arm, that's all. And afterwards, my kids did the same. And everybody, I think that's the right way to go. It's responsible. It's not only your life, it's people around your life as well. I think it's very important that we have to vaccinate.
Some patients have developed many other illnesses after diagnosis and not adhering to doctors' advice.
I'm very, very lucky. I got blood pressure, 120/70. My cholesterol is great, no problems. My eyesight is great. I went to the specialist for my eyesight. They say, can't believe that I'm 40 years with diabetes. There's no mark in my eyes for diabetes. I'm very, very lucky to still didn't have any sight stuff, you know, people losing legs, people they have blind. I'm very, very lucky, really.
Diabetes has been identified as one of the risk factors for COVID-19 patients. Approximately 42% of diabetic patients with COVID-19 have died from the virus. Now, diabetes is, of course, a chronic disease that occurs either when the pancreas is not producing enough insulin or when the insulin that is there isn't effectively used by the body. Now, Principal Specialist and Head of Endocrinology and Metabolism at Chris Hani Baragwanath Academic Hospital, Dr. Cindy Bana, talks to us about diabetes treatment and prevention. We've basically got him with us throughout the show, so we're really going to cover all that is got to do with diabetes. Good morning. How are you, Doc?
Hi, good morning. Thank you very much for having me on your show, and good morning to the rest of South Africa.
Great. I think let's jump right into it. Diabetes. How do you explain what diabetes is to a patient that you've just diagnosed?
So, diabetes is a problem mainly of having a sugar issue. So, when the body cannot handle the amount of sugar that the patient is taking in or processing, the patient will end up with a condition called diabetes. There's many different types of diabetes. You get type 1 diabetes, as Franz just spoke about his condition. You can get type 2 diabetes. You can get gestational diabetes that mainly presents during the, pregnancy, and then you can get pancreatic diabetes. But the general thing is that the patient's going to be complaining of loss of weight, they're going to be very thirsty, and they're going to be passing a lot of urine. Those are the three cardinal symptoms of diabetes. And then, of course, you need to take yourself along to the closest clinic or your GP or any medical person that you know of, and they will test your sugar levels. And it's a simple finger prick. And some pharmacies offer it free of charge. Some people charge a little bit, but the clinics offer it free. And if the sugar level is above a certain level, above 7, then you've diagnosed diabetes. And then, of course, the doctor is then going to try and work out whether it's type 1 diabetes, type 2, or if you're pregnant, or if you've got pancreatic diabetes, and then, of course, manage it accordingly.
So, I think you've touched on these symptoms, the big 3 symptoms that you've highlighted, but I think a lot of people find it difficult to identify or pick out these symptoms out of their whole lives. Maybe, you know, I'm drinking a lot more water, or I'm thirstier because I'm exercising more, or I'm finding the need to, or it's been a hot day. So how do we conscientize patients to the idea that they need to be aware that they might have diabetes by looking out for those symptoms?
Well, first, it's important to know that diabetes is very prevalent. And that means there's a lot of people in South Africa and world over that have got diabetes or are going to be at risk of diabetes. So don't think it can't happen to you and I. I think that's the first thing, is that people need to know that this condition is living amongst us, and don't think that it's not going to happen to you. Once you realize that, then of course, the most important thing is the symptoms. But remember, there's some people that are at higher risk of developing diabetes than others. So, for instance, the commonest of the 4 that I mentioned is type 2 diabetes. 85% of people with type 2 diabetes are going to have a background problem of being overweight or obese. So, the commonest form of diabetes affects people that are overweight. And so we need to watch our weight. We need to be active to keep the weight down. We need to make sure we're eating the right foods. So it can happen to any one of us. And so it still comes back to the 3 common cardinal symptoms that I've spoken about. And that's thirst, passing too much urine, and losing a lot of weight. Now, if we find that we're making excuses to say, oh, I'm drinking too much water because I'm exercising, it's always still worthwhile checking your sugar level. It's simple, it's cheap. Now, there are many other signs, but those are all telling you that the condition's been there for quite a while and that there's already damage. So once it starts affecting the vision, once it starts affecting the feet, which we're going to talk about later in the show, once it started affecting the kidney, you must know you've had diabetes for a long time before it has been diagnosed. And then, of course, at some point, we need to talk about who's at risk from the population in South Africa.
So let's talk about that. Who's at risk? And I want to really focus on type 1 diabetes at this point in time. I think we'll get into the others as the show progresses, because you have mentioned that there are other types. So type 1 diabetes, who's most likely to get type 1 diabetes?
Now that's a tough one, because type 1 diabetes doesn't have a particular look to it. What we do know is that as you move away from the equator, so people that are living in and around Kenya, in Africa, are less likely to get type 1 diabetes than people that are moving away from the equator. For instance, Denmark or South Africa. So we also know that as people move away from the rural area and come into the cities, the risk of type 1 diabetes increases. And type 1 diabetes is an autoimmune condition.
What does that mean?
It means that there's an army of cells that particular person's producing, and that army is now confused, and instead of attacking something from outside of the body, they're attacking the beta cells in the pancreas of that particular patient. And the beta cells are making insulin, and insulin is a hormone that controls sugar. And so when the beta cells are being destroyed and they cannot produce enough insulin, you're going to end up having diabetes. And in this particular case, it's type 1 diabetes. So type 1 diabetes are normally thinner patients, they're normally younger patients, and normally the presentation is quite catastrophic. One day you're fine, like France was, and the next day you become very ill. And so that's the typical pattern with type 1 diabetes. There isn't a strong family history with type 1 diabetes, but there may be a strong autoimmune trait in the family. That means there might be some family members that are having got lupus or rheumatoid arthritis or an underactive thyroid or vitiligo. and generally there is an autoimmune theme in the family, not necessarily one of diabetes.
So with patients that have type 1 diabetes, what's the mainstay treatment? How do they get controlled and get managed from a medical point of view?
So patients with type 1 diabetes require insulin from the onset. So until we get further development in research, and that is changing quite a bit, for now, it is not tablets, it is insulin. So insulin comes in a form of an injection, and it can be injected once a day, twice a day, 3 times a day, or 4 times a day. The more insulin you're willing to use and the more frequently you're willing to use your insulin, the better your sugar levels are going to be controlled, the less likely you're going to have complications, and the more freedom you buy yourself. So you heard Frans saying that his Dr. Han a long time ago at the old Joburg Gen told him that he needs to get his life in order and become quite active and make sure that he's eating the right foods. Remember, the more insulin you're willing to inject and the more frequently you're willing to inject yourself, the more freedom you're buying yourself, and then you're going to be allowed to eat what you can. But if you want to be on a restrictive insulin regimen, you need to be very careful in terms of what you'll be eating, and you need to be more circumspect.
We'll continue this discussion, Doc. We're not going anywhere. We still got you for quite some time. We are talking diabetes today, discussing the different types, different treatments, and of course, how you can find out whether or not you have, or someone that you know and love might have diabetes. Stay with us. We continue the discussion after the ad break. Welcome back. Globally, 90% of people with the condition type 2 diabetes are there. And of course, the increase in the number of people developing type 2 diabetes is driven by a complex interplay of socioeconomic, demographic, environmental, as well as genetic factors. Type 2 diabetes can often be prevented, whilst early diagnosis and access to appropriate care for all types of diabetes can, of course, delay the complications for people living with the conditions. Amabutele is sat down with Brian Midland, who is living with type 2 diabetes. Let's take a listen.
Brian Midland from Gauteng is one of many people living with type 2 diabetes. According to experts, this form of diabetes is associated to lifestyle. Take us to the day you were diagnosed.
Went to the doctor and she said to me, when I examined you the other day, I suspected that you've got diabetes, but the blood tests confirm what I suspected. So I had no symptoms, I didn't suspect it, nothing. The doctor picked it up.
Was there history of diabetes in the family?
My grandmother had diabetes, my mother had diabetes, her brother had diabetes, and now it's come down to me.
Since some members of the Midland family had diabetes, did you try and work on avoiding it earlier on?
Not at all. I never thought about it. I never worried about it.
Talk to us about lifestyle changes as a result of your diagnosis.
Once you've been diagnosed with diabetes, there isn't a diabetes lifestyle. There isn't a diabetes diet. It's healthy living, it's healthy eating, what everybody should be doing. Okay, so it's not a special thing. You've just got to be aware of what is good and what is not good. You've got to change your eating habits. You've got to change, for instance, you've got to drink more water. You've got to exercise more.
Talk to us about a typical day in your life.
In the morning, when I get up, before I do anything, I've got to prick my finger, check my blood sugar levels, and write it in a book. Because that's the important one, that shows how your body is handling the diabetes. And then 2 hours after a meal, I don't do it after every meal, but 2 hours after a meal,
You must test again and see how the food is affecting your body. That one. Before I can eat anything, I've got tablets I must take. When I'm finished eating, I've got tablets that I must take. And again, I've watched what I've eaten. I haven't been able to have nice fresh toast with jam on it. You know, you've got to be conscious of these things all the time.
Many diabetic patients have expressed their views about the high cost of treatment. What are your views?
Well, fortunately, I've got a very good medical aid and they cover everything.
How has joining Diabetes SA benefited you and your family?
Diabetes South Africa, what we do is we organize professional speakers. We get dietitians, we got podiatrists, we get optometrists, a lot of specialists in their field, because these are the things that get affected by diabetes. And I've learned more from these speakers at Diabetes South Africa than what I've learned from the medical profession.
1 in 3 adults locally are at high risk of developing type 2 diabetes. Diabetes is a serious threat to global health that respects neither socioeconomic status nor national boundaries. And of course, we continue our discussion with diabetes being the main topic of the day. Principal Specialist and Head of Endocrinology and Metabolism at Chris Hani Baragwanath Academic Hospital, Dr. Sandeep Bana. Dr. Bana, let's continue our discussion. Before the ad break, we spoke about type 1 diabetes. I think let's move on to the second bit, type 2 diabetes. You lightly touched on it earlier on, but what makes type 2 diabetes such a big problem?
The reason why type 2 diabetes is a problem, and you can see it in our clinic. I mean, we've got one of the biggest clinics in Africa at Baragwanath Hospital. And so we've got about 850 patients with type 1 diabetes, but we've got over 6,000 patients with type 2 diabetes.
Sure.
And that is just a tip of the iceberg, because we cannot accommodate, obviously, everybody. We've got staffing issues. You know, the hospital can only accommodate X amount. But as we control our patients better, we then send them to the peripheral clinics. And there's about 24 different clinics in Soweto, all capable of managing diabetes. So the type 2 diabetes is the much commoner form of it. And like you alluded to, 1 in 3 South Africans are at risk. In fact, there's over probably around 10 to 11% of the South African population that's already been diagnosed. Now, the biggest issue of type 2 diabetes is that we still haven't diagnosed 60% of patients with type 2 diabetes. So there's a lot of people walking out there in South Africa that's already got type 2 diabetes and don't know it.
Sure.
Some of them have not picked up on the symptoms we've spoken about. And like Fran, like our current guest here now, he had type 2 diabetes and didn't even know about it, because he probably got used to thinking that he needs to be passing more urine, or he's always got that level of thirst, and he had a certain weight. So type 2 diabetes is common because obesity in South Africa is common. We all meant to be watching our weight. Anybody who's got a BMI, and that's a measure of what your weight is for your height, above 25 is at risk of developing type 2 diabetes. The higher the BMI, the more your risk of developing type 2 diabetes. He alluded to the family history. So this is the type of diabetes that is common amongst family members. And so there will always be at least 1 or 2 family members with type 2 diabetes. And that should already tell you that you're at risk. He thought he wasn't at risk. And of course, much to his surprise, his GP picked it up. So anybody with a family member of type 2 diabetes needs to be careful. Watch their weight, watch their eating, and make sure that they test themselves regularly, because these are the at-risk population. So we spoke about it before. Somebody with a family history of type 2 diabetes is a high risk. Somebody who's got weight problems is high risk. Somebody who's got hypertension, higher risk. Somebody who had diabetes in their pregnancy is at higher risk. Certain people of certain ethnic groups are at higher risks. So the Indians in South Africa, higher risk. Lebanese, higher risk. Certain Jewish people, higher risk. And we definitely seeing it in the African population as well. And so as we become more affluent, as we become more industrialized, as we move into the cities and we're starting to eat a lot more refined carbohydrates, a lot more junk food, a lot more food with sugar in it, carbohydrates in it, the risk of diabetes is higher.
So in terms of treatment, is the treatment the same for type 1 diabetics as well as type 2 diabetics, or is there a difference?
So here, there's a stronger emphasis on lifestyle. So all the patients need to get to at least 10,000 steps a day, at least 40 minutes of a brisk walk every day. We need to be watching our carbohydrate intakes, and then the treatment's a bit different.
Okay.
So remember, in type 2 diabetes, it is not that they're short of insulin, they are resistant to insulin. So the body is making insulin, but the cells in the body are not listening. And so here in the beginning, you can get away with tablets, and there's various classes of tablets, different types of tablets that you can get. So in the past, there was just metformin or a tablet called an SU. However, now there's a flurry of different diabetic medications that are available on the market that are all designed to not only manage diabetes, but to manage diabetes by decreasing one's risk of heart attack, cardiac failure, and kidney failure. All of these three conditions are more likely to happen in a patient with diabetes than not with diabetes. And so these different classes of drugs, they've got big names, but they are all there to improve one's control. There are different injectables on the market as well. In the past, we only had insulins. Now there's a different drug class called the GLPs, glucagon-like peptides. These injectables will drop a diabetic patient's weight, will help the fatty liver that patients with type 2 diabetes are prone to getting. It will help decrease the risk of hypoglycemia, which is something that patients are at risk of with certain tablets and certain insulins, because as you're trying to improve your control, the price you pay is the risk of hypoglycemia. So all of these new agents, which your doctor or your nurse who's got interest in diabetes can empower you with in terms of when we use it, why we use it, and how is it going to be benefiting you beyond glucose control. Patients with type 2 diabetes mustn't only be focused on their sugar level. They need to be controlling their blood pressure better. They need to be looking after their cholesterols better. And more importantly, they need to be controlling their weights a bit better besides the sugar.
So a really big and I guess diverse way we look at treating diabetes, not just the medication. But I've got a question from Linda. Linda, good day.
Hello there.
How are you?
I'm all right, thank you.
Good, thanks. Your question for the doctor.
So just listening, I'm a type 2 insulin-dependent diabetic, and I have been diabetic now for 17 odd years. My biggest gripe that I have with this disease is that, and I'm sorry to say to the doctor, is that our GPs in this country are not adverse with type 2 diabetes specifically. When I was diagnosed, I was given insulin and told, well, inject this and then you can eat whatever you want and you will be able to manage your blood sugar levels. Nowhere in these 17 years, literally until about maybe the last 5 years, did I actually understand that insulin resistance is the root cause of type 2 diabetes. And this is a lifestyle disease. Nobody ever told me that. Nobody ever educated me in type 2 diabetes. And I'm sorry to say that the clinics in South Africa, the diabetes nurses are not educated enough to educate the people with type 2 diabetes. You'll go to a hospital and they will ask you, for example, if you are checked in, they'll ask you what your dietary requirements are, and you'll say you're type 2 diabetic. I can guarantee you will still get macaroni and cheese for dinner that night. Nobody is actually understanding the root cause of type 2 diabetes. Doctors would rather treat you pharmaceutically with type 2 diabetes than treating you as a lifestyle method. You can reverse type 2 diabetes or put it in remission, whatever the word is that you want to use. It doesn't really, you can't cure it, that I know. But you can, through changes in your lifestyle, change your HbA1c from 12% down to, say, 6% in 6 months, or 3 months in some cases that I have witnessed. I have a support group of type 2 and type 1 diabetics. I've got over 250 people in my support group. And out of that group, I can tell you some great success stories just out of pure education and changing the person's mindset. And I think, sadly, in South Africa, we have far too many people in our lower income LSM who don't understand, or they're not being educated properly by our diabetic nurses, by our doctors. They, like I say, they would rather treat us pharmaceutically than treat us in the lifestyle methods of managing your type 2 diabetes. The doctor just spoke just now about other injectables that are now available for type 2 diabetics. I can tell you, I tried it. Well, I tried to apply for it through my doctor about 2 years ago. It was rejected by my medical aid. It would mean I would have to spend about 3,500 to 5,000 rand a month more just to get that particular injectable. They'll cover my insulin, but they won't cover that injectable. And I think the system that we have is so wrong and so flawed, and it's not spoken about enough. We don't have an annual diabetes summit. I think maybe there's the first one happening next year maybe. But we don't, it's not like the rest of the world. It's not like the other first world countries who talk about this all the time. I'm on so many international support groups, and I've taken it upon myself to educate myself about my disease and take responsibility for what I put in my mouth at the end of the day, because the food that we have on the shelves is just not conducive to a healthy lifestyle, and we struggle every single day. I see it every single day. Linda, what can I have for breakfast today? Can I have wheat bix? Can I have all-grain flakes? Nobody's talking about the amount of carbohydrates and the macros and macronutrients we are supposed to be consuming. Nobody is educating people with this disease every single day. They would rather say, no, everything in moderation. I'm sorry, that's an old cliche that should have gone out of the window donkeys years ago when it comes to health, not only about diabetes, about anybody's health. Everybody's saying, make sure you have 3 meals a day and 2 snacks in between. What a load of nonsense. Every time we eat, we spike our insulin. Our insulin works every time we put something into our mouth. But that doesn't mean to say it works for me. Because it doesn't work for me, it's not going to work for you. We all have a different microbiome. We all have a different body. Our bodies are different. We metabolize food differently. So when nutritionists and dietitians give everybody one diet plan that is blanket for diabetics, it's wrong. Work out what works for you. A slice of bread, of whole wheat bread, will spike my blood sugar into double digits. But for you, as another diabetic, it might not do that. It might spike your blood sugar by 2 or 3 points.
For sure.
But for me, if I have blood sugar pre-meal, blood sugar of, say, 6.5, and I have a slice of toast with peanut butter, I can guarantee you 2 hours later my blood sugar will be 15 or 17 at least.
Well, thank you, Linda. I think we got the gist of what you're saying to us this morning, and I think we'll highlight and get into it with Dr. Bana after the ad break, because we really are talking about diabetes, you know, where we find ourselves, what the treatment currently looks like, and where we stand. And it's so important to get the views of actual patients, people on the ground that have had to deal with this disease for years and years and years, and what the future may look like with respect to treatment. We continue our discussion with Dr. Bana, and we're talking diabetes after the ad break. Welcome back. This is Vital Signs. I'm Dr. Musa Mtombeni, and we continue our discussion with Principal Specialist and Head of Endocrinology and Metabolism at Chris Hani Baragwanath Academic Hospital. Dr. Cindy Bana educates us about factors as well as all the things that have got to do with diabetes. And in this part, we'll be looking at education and, of course, some of the ways that we look at managing diabetes outside of actual medication. And, of course, we'll be looking at the complications that come with having diabetes. Dr. Bana, let's, before we went to ad break, Linda really highlighted some important points that have got to do with education and highlighting just management of people that have diabetes from a broader perspective. Are these tools that are given to patients when they are diagnosed?
So, you know, before I address that question, I mean, that was such an empowered patient that you just heard on Linda. I mean, Linda took it upon herself to try and educate herself about a condition, empower herself, and then try and make changes. And of course, through her WhatsApp group, she's trying to make sure that she helps others as well. So the one thing we need to realize is that Linda pointed it out. This is a lifestyle condition. So we as South Africans, patients living with diabetes, patients that are overweight, we need to take responsibility and say, this is our problem. You cannot change your genetics, but you can change your environment. You can change your epigenetics. So by being active, by being cognizant that your weight has an impact on the risk of type 2 diabetes, you've got to empower yourself. You see, one of the key things Linda mentioned is that she thinks the general practitioners in South Africa are not clued up enough in terms of managing this. Well, you know, that's not going to change. The number of patients who are living with diabetes, there aren't enough doctors in South Africa. There aren't enough endocrinologists. There aren't enough diabetologists to manage this. So number one, the patient's got to take responsibility. This is your condition. Yes, it's genetic, but lifestyle caused it. So if you're waiting for somebody else to tell you to change your lifestyle, it's not going to happen. Governments are meant to be doing this. But remember, we vote our government in. We vote the government in Zimbabwe. We vote the government in India. We vote the government in Japan. So wherever it is, we have to empower ourselves to say, if we vote this government in, it better take care of everything. It can't take care of everything. And so there's too little money left in the pot. And so from that perspective, unfortunately, a lot of the focus in our health moved towards HIV and TB 15, 20 years ago, because those patients suffering with HIV and TB created focus groups to force government to look at those conditions. So patients with diabetes need to pick up the flag and say, we need government to fight for us. Because at the moment, if we don't get this thing right, HIV and TB will pale in comparison to what diabetes is going to do. There are more people dying of diabetes-related conditions than HIV, TB, malaria, and road accidents put together. So it's, the epidemic is here already. We all need to empower ourselves. So from a dietary perspective, don't wait for somebody to tell you this is healthy or unhealthy. Empower yourself. That information is out there. It's in the media. It's on the internet. It's on Google. Carbohydrates equates to obesity. Obesity equates to diabetes. So Linda had to empower herself. But the other key thing Linda said is that every individual is different. And so it's about individualization. Now, a doctor is not enticed to spend half an hour, 45 minutes with the patient suffering with diabetes. The medical aid pays them 200, 300 Rand for a consult. Listen, if they're going to see 1 hour per patient, they're going to get to see 8 patients in a day. There's no way they're going to even able to pay the rent, leave alone their loans. And so that's no excuse. Doctors are meant to be doing their job, but the diabetic educators are there. There's a lot of stuff online. Diabetes South Africa, Linda's group, there's many groups like that. You need to empower yourself, but doctors are supposed to be telling the patients the importance of diet, the importance of exercise, giving them eating plans, directing them broadly into saying carbs are a problem, foods with protein and fat and healthy fats are better. So, but no, we're sitting with an epidemic. It's going to be impossible for 60 endocrinologists to manage it. So each institution, each practice will find hopefully a champion. And we've managed to change diabetes around at Baragwanath Hospital from having a clinic with just 1 doctor a few years ago. We now have 7 doctors full-time taking care of patients with diabetes. I've got excellent diabetic educators. Between the 3 of them, they've got over 100 years of experience. And they've been doing this for a long period of time. But Linda's right. All the clinics don't have that. Because the nursing system in South Africa doesn't recognize diabetic educators and reward them accordingly. They're not allowed to be promoted. So South Africa's got a lot of issues. Government needs to focus on obesity and type 2 diabetes. Otherwise, they're going to be in trouble. The universities and the technicons need to change how nursing takes care of diabetes. And patients need to take responsibility and say, I've got diabetes, I better empower myself. And she's right. Just through diet and exercise, you can influence insulin resistance and even put your condition into remission. But it's easier for people to just be given tablets. How many of us actually do 10,000 steps a day? Not just for preventing diabetes, just for normal lifestyle. France told you. And the second patient said, everybody's meant to be leading a healthy lifestyle, not just to prevent diabetes, just to be healthy.
Look, very important points that are raised, and I think a big take from this is the fact that once you have been diagnosed, that is your diagnosis, and you need to take charge of your diagnosis and get the best treatment for yourself. Very quickly, Jita from Chatsworth would like to ask you one more question, Dr. Bana, before you head off. Jita?
Hello?
Hi, yes, your question for the doctor very quickly, please.
Okay, I am on insulin. I take 22 units at night, and I take 1,000 mgs of glycopage in the morning and then 1,000 milligrams at night. I heard the doctor say that the insulin is better for diabetes. If I want to take it in the morning, do I have to consult my doctor and then have and take, or can I just take twice a day?
All right, a question that I think we already know the answer to. Dr. Bana, can she switch around her medication to what makes sense to her? She says she's on 1 gram BD for some of the oral medication and is also on 22 units of the insulin. Can she switch it around?
So the glucophage can be basically, you get the slow release and you get the normal one. The normal one normally needs to be taken before meal. The slow release can be taken once a day, anytime, because it works for 24 hours. The insulin, if she's on just one insulin, 22 units a day, it's probably a long-acting insulin. In other words, she can swap it. Always consult with your health practitioner, be it a diabetic educator or a doctor. But if you're on a one long-acting insulin, there shouldn't be a problem, but consult your doctor. That would be important. Remember, because it's working over a 24-hour period.
Yeah.
Whereas the ones that have a short-acting component that are specifically designed to work for a particular meal, it's not as easy as swapping it around without some advice. But Geeta also mentioned an interesting thing. She's already on insulin. Remember, like Linda said, if you take charge of your condition early with type 2 diabetes, you can put yourself into remission. There's no reason why you would have to go onto insulin. It's once that beta cell fails, you have to then start taking insulin. But you alluded to earlier on this segment, we were going to talk about some of the complications of diabetes. And that's what you're trying to prevent, is that once you've got diabetes, there's going to be a problem. And the problem is that you get small blood vessels that can get affected and big blood vessels that can get affected. The small blood vessels causes microvascular complications, micro meaning small, and that will affect eyes, eventually causing blindness. It will affect kidneys, eventually causing kidney failure. And it will affect the nerves that are supplying the body with nerve supply, and that will eventually cause problems with the feet. In men, it may affect their sexuality as well. Macrovascular, which means the big arteries get affected, it eventually causes heart attack and stroke. And remember, cardiac failure is very high up as a complication in patients with diabetes. So that's what we're trying to prevent. And if you don't bring your weight, blood pressure, cholesterol, and sugar under control, you need to know your numbers. That's what we've got to look forward to. And those complications become very costly, both from a lifestyle perspective and then from a pharmacoeconomic perspective. It costs the medical aids and governments a lot of money.
Thank you so much, Dr. Bana, for joining us today and really going into diabetes, the different types, the management, and of course, the big complications that you need to watch out for, because it does really cause a problem. Rather prevent the big things before they happen. Otherwise, you find yourself spending lots of money. And of course, we know how expensive that is. That was Dr. Cindy Bana, the Principal Specialist and Head of Endocrinology and Metabolism at Chris Hani Baragwanath Academic Hospital. After the break, we speak to Martin Prinsloo, the National Chairman of Diabetes South Africa. Stay with us. Welcome back. This is Vital Signs. I'm Dr. Musamtombene, and today we're talking all things diabetes, the importance of this very, very big and important disease that has got so many people dealing with so many problems. I think from a practical perspective, a lot of people actually see the end result of diabetes, where, the complications that were mentioned by Dr. Bana are really outlined, where people find themselves with, toes that are starting to become black and they fall off, or having to have amputations, people that find themselves getting heart attacks or getting strokes, people that have kidney problems and other problems that have come about just from the fact that they don't know that they have diabetes and live their lives for so long before they actually get a diagnosis. So it's important to go out there and really know your numbers. I think this is one thing that we've preached on our show for many a time, where we find ourselves just telling you, just know your numbers, whether it's blood pressure, whether it's your diabetes numbers in terms of glucose and things such as that. So go out there, know your numbers so that you can start preventing severe disease. Now, the increase in prevalence, of course, of diabetes in South Africa confirms that this condition is a significant challenge to the health and well-being of individuals, but as well as families in this country. Now, one of Diabetic South Africa's most important roles, of course, is to voice or be the voice for the people with diabetes in South Africa. And of course, to lobby for improved services and availability of essential medications. We've got Martin Prinsloo, who is a national chairman for Diabetes SA, and he talks about the importance as well as the impact the organization has. Good day, Martin. How are you today?
Yeah, well, thank you. And thank you very much for the opportunity to be on the show.
Great. So let's get straight into it. What does Diabetic South Africa do? What do you lobby for?
Okay, Diabetes South Africa is a registered national non-profit organization and a member of the International Diabetes Federation that represents over 230 diabetes organizations in over 170 countries. Previously known as South African Diabetes Association. Diabetes South Africa has been in existence for since 1969. Port Elizabeth had a support group in the early 1960s and was encouraged and guided by Professor Francois Bonici and Josina Barnes from Cape Town. That's where it all started.
Mr. Prinsloo, let me ask you this question before we run out of time. What are your aims as an organization? In an ideal world, what do you see happening in terms of South Africa and diabetes?
Right. Our aim is to encourage people to live a normal life, to lead them in doing that, and to see where we can help people with diabetes.
And how can people go out there to get the information that they want about Diabetic South Africa?
Just come back. You broke up there a bit.
Pardon?
What were you asking there?
Oh, I was saying, how can people get information and more information about Diabetes South Africa?
They can call me on 082 579 9059 anytime.
Anytime. Well, Mr. Prinsloo, I hope it's not 24 hours a day, but I think you're so passionate about this that you're willing to take all their calls at all times of day and night to make sure that they get the help that they want. Thank you so much for joining us and really giving us a perspective on what Diabetic South Africa, or Diabetes South Africa rather, really does and what their focus is. Really getting information out there, creating awareness, and of course lobbying for people with diabetes to get better access to infrastructure, to care, to medication, and of course support in all shape, ways and forms. If you're sitting at home thinking, I've been gaining a little bit of weight, or I've been losing a little bit of weight, and I'm worried that I might have diabetes, please go out to your nearest health center and get tested. It's a simple fingerprint test, and of course they will take it from there and make sure that you get the information that you require to get to know your numbers. From me, Dr. Musamtombene, thank you so much for participating and watching the show, and of course thanks to our guests for being on the show. This is Vital Signs. We'll see you again soon.